For lipid metabolism, right, the most important thing that we need to remember is why does our body want lipids? So, obviously, lipids in excess can cause atherosclerosis and xanthomas, and in some cases, it can also cause pancreatitis, and those are all bad conditions. But despite that, we still need lipids in our body. And do you guys remember why we need lipids? So, there are three important features or functions of lipids. So do you guys remember those three? So they're firstly responsible for maintaining the cell membrane. They help in formation of the cell membrane. The second one is that they help in formation of hormones because we have fat soluble hormones. And then the third reason is because they're responsible for enzyme activity, some enzymes. So fat soluble hormones, vitamins, fat soluble vitamins, and then the cell membrane, also some enzymes. So those are the reasons why we need lipids in the body. Now, the way our body kind of metabolizes lipids, right, is that lipids, they usually like clump together because they're hydrophobic. So when you put lipids in water, and a majority of the diet we can consume is water. So because they're not very friendly with water, they would instead like form bigger molecules, and we don't want that to happen. So we firstly convert lipids and fat into these small molecules called micelles. Now micelles are like small pockets of lipids. So from a bigger molecule, we've now packaged them into smaller molecules. And the reason why we break them into smaller molecules is because we want to break them down. So these smaller molecules then get broken down by the pancreatic lipase enzyme, and then the broken down components get absorbed into the cell. Now there is another problem with absorbing lipids into the cell, that you cannot directly absorb the triglycerides into the cell. So what our body does instead is it breaks down the triglycerides by the enzyme lipoprotein lipase. It breaks down the fats or triglycerides into free fatty acid and glycerol. Both of these then get absorbed into the intestinal cell, where they get remerged into triglycerides. And when they're remerged into triglycerides, cholesterol, they get packaged into a molecule called a chylomicron here. Now, chylomicrons are very big molecules, and because of them being so big, they cannot normally enter the small blood vessels which connect the base of the intestine. So instead, they enter the lymphatic system, and they enter the lymphatic system through a lymphatic vessel, which is called as a lacteal. So they enter the lacteal, and then through the lymphatic system, they eventually reach the thoracic duct, and then from the thoracic duct, they can enter the venous system at the subclavian vein. Now, in the subclavian vein, they have three places they can go, the chylomicrons. Either they go to the adipose tissue, where they can deposit some of the triglycerides and cholesterol for storage, or they could go to the muscles, where they can again give some triglycerides and cholesterol for energy. And the third location is the hepatocytes. Now, here you might see that it's not actually a chylomicron anymore, it's a chylomicron remnant. And the reason why it's a chylomicron remnant is because the chylomicron has already shrunk in size because of deposition of the triglycerides and cholesterol at the adipose tissue and the muscle cells. So these remnants, they get taken up by the liver. Now the liver is also producing a lot of triglycerides and cholesterol. And the reason is because those components, triglycerides, cholesterol, fatty acids, all of that is actually very important for our body, namely for the three functions that we said. So because the liver is also producing a lot of cholesterol and triglycerides, the chylomicron remnant and the extra cholesterol, triglycerides, and lipids, they get merged into a bigger molecule called a VLDL. Now these are very low density lipoproteins. Now the function of VLDL is to transport the transport cholesterol and triglycerides from the liver to the body. So these VLDL, they can either again go to the adipose tissue, they can go to any of the cells which needs lipids, and the more it travels, the more it reduces in size because it's depositing more of that lipid. And from a VLDL, when it's reduced significantly, we'll call it an IDL, which is an intermediate density lipoprotein. And then from an IDL, it will shrink even more to a low density lipoprotein. Now, these low density lipoproteins, usually they get absorbed by cells, but sometimes when they don't get absorbed by cells for use, they can be consumed by macrophages. And now macrophages, when they consume a lot of LDL, they will deposit on the walls of the blood vessel as lipid-laden macrophages. That means the macrophage in itself has a lot of lipid. And then when you have accumulation of these kind of macrophages, that will be the start of production of a cholesterol plaque or an atherosclerotic plaque. Now, after all of these, there is one more lipoprotein that we need to discuss. It's these small, high-density lipoproteins. Now, we talked about lipoproteins in a way where they go from the liver to the periphery. Now, low-density lipoproteins actually do the opposite. What they do is they go from the periphery, from the cells, to the liver. And what they do in the meantime is they would collect any of the free fat which is in the blood, or any of these low density lipoproteins which are about to be degraded, or they can take up some cholesterol or triglycerides from the macrophages which have become lipid laden. So they take all of that fat and deposit back to the liver. And now, because they're depositing cholesterol and lipids from the blood and from the periphery to the liver, they're considered the good fat because they're clearing your body of lipids. And then obviously the liver, it can produce bile with the cholesterol, and then it can be excreted, the lipids, I mean, through bile. So that is a brief overview of the lipid metabolism cycle. So any questions about this? Wait, can you guys hear me?
Yeah.
Okay.
I have a quick question, Dr. Taha. So when we are talking about the lipoprotein lipases, so some of the questions they ask, like, if we have especially the PCSK9 inhibitors, so meaning
Yeah.
we are trying to inhibit the LDL receptors on the liver, or how we are clearing the cholesterol with that medication, those
Yeah. So
inhibitors,
I can.
PCSK.
Yeah. So the idea with the PCSK9 inhibitors, right, is that it degrades the LDL receptors. And now, because we're inhibiting this enzyme, we're inhibiting the degradation of the receptors. Now, if we go to our original diagram, if you break down the receptors, then your body or the peripheral tissue, it's not absorbing the LDL. But if you keep the receptor open, then the cells will absorb more LDL. So it will be cleared from the blood, and that is how they work. They're reducing the overall LDL level in the blood by storing it within cells.
So PCSK9 itself is degrading the LDL receptor on the liver. So then we need inhibitors to inhibit the degradation of LDL receptors, so they can take, they have more LDL receptors attached on the liver, so they can take more cholesterol from the serum, right?
Yeah.
Okay,
Yeah.
thank you.
And then one thing here is that it's not necessary that the LDL receptors would only be on the liver. A majority of them would be in the periphery. So that's why you deposit these fat molecules in the peripheral cells. Okay.
Okay.
After that, let's go to So for the autonomic receptors, right, a couple of things we need to remember. There's two major, or rather three major types of receptors. You have the muscarinic receptors, the nicotinic receptors, and then the adrenergic receptors. And they all perform differently. There's multiple subtypes, but these are the three types of receptors. Now, the nicotinic receptors, right, they're located in two very important regions. So the first is they're located between neurons, and the second is that they're located at the neuromuscular junction. Both of those are nicotinic receptors. And in nicotinic receptors, the neurotransmitter used is acetylcholine. And then the next type of receptors that we have is we have the muscarinic receptors. Now the muscarinic receptors, they also use acetylcholine, but they belong to the parasympathetic nervous system. And then one thing about the parasympathetic nervous system is that the distribution is craniocaudal. That means only the brain and the sacrum. Those are the only locations from which you'll have parasympathetic activity. On the other hand, the adrenergic receptors, which actually use norepinephrine or epinephrine, they are located in a thoracolumbar distribution. That means the thoracic and lumbar spine. That would be the area where you have sympathetic innervation, like originating from. And the reason why it's there is because along with the spinal cord, we also have the sympathetic chain. And I believe we have an image coming up soon. Okay. Now, one more thing to note is that the difference between parasympathetic and sympathetic innervation is that in parasympathetic innervation, you have a much shorter postsynaptic neuron compared to sympathetic system where you have a much longer postsynaptic neuron. Finally, when these receptors are activated, usually uh, they're neurotransmitters which activate the receptors. However, there is one exception in that there sometimes when the adrenal gland is stimulated, it releases epinephrine, which is actually a hormone instead of a neurotransmitter. So what it does is it enters the blood, and then through the blood it activates all these receptors. Now, one more difference between norepinephrine and epinephrine is that norepinephrine activates all the receptors except B2, and then epinephrine activates all the receptors including B2. And then, yeah, this was the muscular junction that I told you. It's the nicotinic receptor.
Sorry, did you say no epinephrine activates everything, including B2, but epinephrine does not activate B2?
Yeah, so norepinephrine does not activate B2, but then epinephrine activates B2. That's what I meant.
Okay, thanks.
Yeah. And then we also had the types of receptors. Wait. So now these mechanisms, right? You do need to remember them. There's not a lot you can bypass. You do need to remember that M1 has the Q channel, so GQ protein, and then M2 has the GI protein. So you do need to remember them. But there is a good mnemonic here, which is KISS. So QISS, quiz, quip, and then even if you don't remember these ones, that's all right. But do remember these ones. So quiz and quip, keep. So yeah, so those are the receptors. Now one thing is that for adrenergic you have these 5 receptors, alpha 1, alpha 2, and then for beta you have 3 subtypes of B1, B2, B3. Similarly, for cholinergic you have 5 subtypes, but only 3 are important, which is M1, M2, M3, and then M4, M5 they're very low yield, so we don't really learn about those. Dopamine has 2 receptors, histamine has 2 receptors, and vasopressin has 2 receptors. So let's quickly go over what these receptors do. So alpha 1 receptors, they increase vascular smooth muscle contraction. So what do you think? What effect would this have on the blood pressure?
Increases the blood pressure.
Yeah, so it will increase the blood pressure. And along with that, that is the most important one you need to know. And then along with that, it will also cause pupillary dilation. Those are the important ones. Now for alpha 2, we need to remember that it actually decreases the sympathetic outflow. And this, the reason why it decreases sympathetic outflow is that it acts as a feedback receptor. So when you have a lot of norepinephrine release, it will activate both alpha 1 and alpha 2 receptors. So that once the alpha 2 is activated, it will inhibit more release of norepinephrine, thereby normalizing the effect. So as a feedback, it works as a feedback. And then the other important thing to remember is that alpha 2 receptors, they actually decrease insulin release. This is actually very important to remember, that alpha 2 receptors can decrease insulin release. On the other hand, beta 1 receptors, so we know that beta 1 receptors, they increase like heart rate, they increase contractility. But the important thing to remember here is that they can also increase renin. And then what do you guys think renin will do?
Increase the BP as well.
Yeah, that is true. Renin will also increase the blood pressure. And then along, no, so not along, but like the way it increases the blood pressure is through the renin-angiotensin-aldosterone system. Now for beta 2, usually the effects are kind of opposite, not opposite, but similar. So you have vasodilation, you have bronchodilation, so you have dilation. And except for these, right, you do need to remember this part, that it increases insulin release. That's the most important one. And then increase in potassium uptake and glycogenolysis. Not glycogenolysis, but this increase in potassium uptake, that's a effect of the increase in insulin release. Okay. Finally, this here is another important thing, that because beta 2 receptors, they cause bronchodilation. So yeah, because beta 2 receptors, they cause bronchodilation, then we know that when you block the beta receptors, it will cause bronchoconstriction. And this reason that a beta 2 blockage will cause bronchoconstriction is the reason why we do not give beta blockers to asthmatic patients, because they already cannot breathe properly. So if you were to block the beta receptor even further, then that will just be very problematic for them because of the bronchospasm. Then finally, we have this receptor B3. It's not a very prominent receptor, but the USMLE likes to test beta 3 receptors and bladder relaxation. And then sometimes they can also give you a medication which is called mirabegron, which specifically acts on the beta 3 receptors. Then for the cholinergic or the muscarinic,
What's the name of the medication again? Mira what?
mirabegron. I think I'm pronouncing it wrong, but I'll write it in the chat.
Okay.
Yep. I think my spelling is also wrong, but it's similar to this. I'll show in first aid, like soon. So then for these cholinergic and specifically the muscarinic receptors, you just need to remember the location, which is that M1, it usually affects the CNS or the nervous system, all nervous system. Sorry. Yeah, nervous system. Then M2 is for the heart. And then M3 is for everything else. That's how you can remember them. And then because it's the parasympathetic system, it will decrease everything. That means if it's, so here, I mean, it's stimulating enteric release, and I'm not saying that it will decrease it. That means it will be more of a resting state. So rest and digest. So that's why it will increase digestion, it will decrease heart rate, it will increase glandular activity. and all of those things. Next, we have dopamine. Now, dopamine, it does have like two receptors, and one important thing about dopamine, right, is that it exhibits a dose-dependent effect. That means at higher doses, dopamine will have different effects. So one example here would be that low dose dopamine, it can cause bronchodilation, not bronchodilation, but like vasodilation. And then as you increase the dose, it can also cause hypertension. And that is why we can use like high to medium dose dopamine for the treatment of shock. And then there are two receptors. Now you can remember that D1, it's usually present in the renal vasculature, and then D2, it's actually it modulates neurotransmitter release. That's what they say. But what I would like to tell you about D2 is that remember that a lot of antipsychotic medications, especially the first generation antipsychotic medications, they work on the D2 receptor. Next, we have H1 and H2 receptors for histamine, and this is important. This line here is important that the H2 receptors, they specifically increase gastric acid secretion, and the H1 receptors, they do everything else. Furthermore, uh, there are certain important things about histamine that I would like to point out, and then that is there are two classes of histamine, right? There's like the first generation antihistamines, and then there's the second generation antihistamines. Now, the reason why we cannot give first generation antihistamines to elderly people is that first generation antihistamines, they can cause dizziness. They cross the blood-brain barrier and they can cause CNS depression. And then because they can cause CNS depression, these people, they're at an increased risk for falling down. And you don't want elderly people falling down because they can develop hematomas, they can develop fractures, and it leads to a severe disability. Finally, we have vasopressin. Now, vasopressin also has two receptors, so it has the V1 and V2. And even if you don't remember these, that's all right. But I would tell you that remember this part. The V2 receptors, they help in upregulating aquaporin 2 channels. So that is all for the receptors. Now let me. Okay, yeah. So the secondary messages, right? There's two major functions that you need to remember, or like two major pathways, which is the GS-GI pathway, and then the GQ pathway, protein like phospholipase. So we'll go over the easy one first, which is like the GS. And here the S is actually it increases the activity of protein kinase, and then GI would be the inhibitory variant. So how this works is that GS protein, it causes some so when the ligand is bound to the receptor, it causes a change in the structure of the protein, which basically converts ATP into cyclic AMP, and the enzyme responsible for this is adenylyl cyclase. And then the cyclic AMP activates protein kinase A, which gives you the effect. Now here they've said increase in calcium, but you can just remember that it increases the effect of the hormone. Once again, ATP goes to cyclic AMP through adenylyl cyclase, and GS will stimulate it, while GI will inhibit the action. Next, we have GQ proteins. So again, similarly, when the ligand binds to the receptor, you'll develop some structural changes in the GQ protein, which activates this enzyme called phospholipase C. Now, phospholipase, right? Because it's phospholipase, it will break down certain parts of the cell membrane, and specifically the PIP2, which was phosphoinositol pyruvate 2, I believe. So it will break down PIP2 and it will convert it into two proteins. It will convert it into diglycerol. So I'm not sure what the exact full form is, but it's diglycerol, diacetyl glycerol, or something similar. So it will break it down into DHE and IP3. and then both of these eventually activate the protein kinase C. Now, one difference between these two pathways is that in the pathway for GQ proteins, you have an increase in calcium, which leads to activation of protein kinase C. And then in the GSGI pathway, you first have the activation of the protein kinase A, which then leads to a physiologic effect. And in a lot of circumstances, the physiologic effect is based on calcium. So here you have calcium intake or calcium increase before the physiologic effect, and here you have increase in the enzyme followed by the physiologic effect. That means increase in calcium. So those are the two major pathways you need to remember. There are a lot of smaller pathways which include the receptor tyrosine kinase, and it follows a similar pattern. The only difference is that instead of a structural change in the GS or the GQ protein, the receptor tyrosine kinase itself phosphorylizes and then it starts the cascade. So those are the two pathways. So any questions with the topics that we did? So with the receptors or the pathways or lipid metabolism?
What type of question may they ask regarding these receptors, like the GS and the GQ receptor?
Oh, it's actually pretty weird, the type of questions they ask, and they'll usually give you like a ligand. They might tell you that, oh, we gave the patient, let's say, some medication, and let's say it blocked. Sorry, we give the patient an alpha 1 blocker. Okay, so they tell you that, and now you know that it's a GQ protein. So then they can tell you, okay, what secondary messenger would be reduced. So they can give you maybe calcium is reduced. They can tell you, oh, maybe like CAMP is reduced, which is cyclic AMP. Or they can tell you, oh, protein kinase A is reduced. Or like what secondary messenger is reduced. That is one type of question they ask. And they're usually pretty easy. Sometimes they might also tell you that, oh, we gave the patient some kind of medication which activated phospholipase C. So then what would be the next molecule that is produced? And then that would be IP3. So it's more of a memorization thing that they ask.
Yeah, seems so.
So any more questions about the receptors? No? Okay. So for grief, we all know what grief is. It's that feeling of loss when someone dear to you has died, or because of loss of something important. It doesn't always have to be like a person. Sometimes it can also be an object. And the only thing you need to remember is that if grief is for a long time, which is like 6 to 12 months, then it's a pathologic thing where it's a prolonged grief. But if it's less than 6 months, then that is completely all right. And it is completely normal for patients to have hallucinations during grief. And the hallucinations will classically involve seeing images of the death of the loved one or hearing voices of the loved one, but they will all be related to some hallucination relating to the grief or relating to the loss. It won't be random voices or seeing aliens, not something like that, but instead it would be always something related to the loved ones, the hallucinations. That's all you need to remember for this one. And then obviously, yeah, grief and major depressive disorder, they're completely separate diagnoses. So the symptoms that the patient describes in grief, they will not meet the criteria for major depressive disorder or any other psychiatric condition for that matter. Yeah. Next, we have normal infant and child development. Now, this topic, I'll tell you that it's a very stupid topic in my opinion, because you do need to just memorize all of this. You do need to memorize all of this. There's no way around it. And
So for prolonged,
yeah.
sorry, for prolonged grief, how do we differentiate between prolonged grief and MDD?
Oh, so in MDD they have like a certain set of symptoms. The symptoms are recognized by the SIG-E CAPS mnemonic,
Yeah.
and then
Mm-hmm.
for MDD you need like at least 6 symptoms over a period of 2 weeks, along with one of these two symptoms, either a depressed mood or ahedonia, and they both mean the same thing, like a loss of pleasure or like low mood. So that is the criteria for major depressive disorder. But even if you develop like 5 symptoms out of the 6, you still don't classify for major depressive disorder. So if someone describes grief, then they will not have all 6 of those symptoms.
Okay.
Yeah. So there are
Thanks.
8 symptoms, and you need like a minimum of 6. Yeah. And then for these topics, you do need to memorize these. You might get like, yeah, you might get a question, you might not even get a question. It's not that important. But yeah, you do need to memorize these. Or like, not even memorize, just have a rough idea of what these symptoms or like, sorry, milestones are, not symptoms. Then we can just directly go to pathology. Now, the first topic here, right, is child abuse. And what do you guys think? What condition is most commonly confused with child abuse?
Osteogenesis imperfecta.
Yes. Osteogenesis imperfecta is the condition which is most commonly confused with child abuse. And the reason is because patients with osteogenesis imperfecta will usually come in with multiple fractures. Now, the way you can differentiate between the two is that patients with osteogenesis imperfecta will have a lot of fractures without bruising, and patients with child abuse will have fractures with bruising. That's how you can differentiate between them. Now, there are a couple of variants of child abuse. You have neglect. That means the baby is not looked after. This can lead to like most commonly malnutrition. And yeah, that's all for it. Like neglect, usually patients will present with malnutrition, and the baby will be neglected by parents. Now, physical abuse is usually, yeah, see, fractures with bruises. One. Additionally, there is one specific condition which is called the shaken baby syndrome. This is what the USMLE will go after, and you will get at least like one question from this on the exam. What shaken baby syndrome is, right, is that the child is held very tightly, so tightly that it actually breaks the ribs, and shaken very harshly. Now, because the baby is shaken so harshly, they can develop hemorrhages. So they can develop retinal hemorrhages in the eye, and along with that, they can also develop subdural hematomas. And the reason why they develop subdural hematomas is because of the rupture of the bridging veins, and along with that, they'll develop these retinal hemorrhages. Now, one question that the USMLE asks is, if you have a baby who has come to you or like brought to you by parents for shaken baby syndrome, like you diagnose it as shaken baby syndrome. So what do you think? What is the first thing that you want to do for these patients? Do you call child protective services or do you do something else?
Control the bleeding,
Yes.
then save the baby first.
Yeah, that is 100% correct. The first thing you want to do for patients who've been abused and they have like severe symptoms is you want to stabilize those patients first before you start questioning the parents or before you start calling child protective services. Before anything happens, you want to look after your patient and you want to make sure that the patient will survive. And to do that, you stabilize the patient first. Maybe the patient needs some IV fluids, maybe they need pain medications, anything. You need to, uh, sorry, you need to stabilize your patient. Next, we have sexual abuse. Now, usually, sexual abuse will be, uh, yeah, usually males are the most common abusers, and then that's one statistic that you do need to remember. And one more thing you need to remember is that whenever you have a child with sexual abuse, you need to give them three things. What do you guys think? What would those three things be? So the first thing you give them is immediate prophylaxis for UTIs and STIs. The second thing you give them is a birth control or like an IUD. And the third thing you do is psychiatric evaluation or counseling. These are the three things you need to do whenever someone with sexual abuse comes to you. Usually it's 9 to 12 years of age. So for these patients, you wouldn't really think about contraceptives, but that depends case to case. So not for these patients, but if it's an older person, then you immediately do want to give them some kind of contraceptive. And then the reason why you would lean towards IUDs is because they have a much higher rate of success compared to other contraceptives, such as the oral combined contraceptives. Yeah. Then next we have emotional abuse. Now, in emotional abuse, you'll usually develop these it's a very opposite spectrum kind of thing, where either you develop babies who are very overly affectionate after the emotional abuse, or you develop patients who are very aggressive. These are the two variants that you might see. I'm kind of blanking out on the name, so I will try to message the name in the group. But one is develop. No, wait, sorry, no, it's not that. Disruptive mood disorder, where you have like an aggressive child, and then the overly affectionate one is the one I'm blanking out on. So I'll find out the names and I'll send it in the group. But these are the two variants which can happen. Either they're very affectionate towards any attention that is given to them, or they become very aggressive towards any attention that is given to them after the abuse. So when they're relocated to like a different household. Finally, we have this vulnerable child syndrome. It's a very low yield condition. And the idea here is very simple, that parents usually think that their children, they're more prone to harm, and it's more of a protective instinct. And that is why what they would do, sorry, is that they would try to bring the child to the hospital a lot of times. Think of it as a hypochondriac person, but instead of the person actively coming to the hospital, they're bringing their child. Now, here they also say it's very different from a facilitative disorder imposed on another, and that is because facilitative disorder, people with facilitative disorder, they would also bring their child in to the hospital multiple times. The difference here would be that vulnerable child syndrome, you won't see any actual illness in the child, it's just a concern. Whereas in facilitative disorder, you'll see very severe symptoms. One example would be that a mother injects her baby with insulin and then brings him to the clinic for hypoglycemia treatment. And the reason why people with facilitative disorder do this practice, I would say, is because they require, or not require, but they crave medical attention. And this one, remember, is imposed on another. You can also have a facilitative disorder imposed on self, which is just that patient actively takes, let's say, insulin to reduce their blood glucose so that they can be brought to the hospital and be looked after by medical professionals. Now, this is a problem because, yeah.
I wanted to ask if this is different from Munchausen.
Oh no, it's the same. So it's the same thing. It's just facilitative disorder imposed on another is Munchausen imposed on another, and then you also have Munchausen syndrome.
Okay,
Yeah.
thank you.
And what I was saying was, yeah, facilitative disorder. The reason why they do this is to get the attention from medical professionals, and the reason why it's so bad is because you're wasting up important hospital resources and unnecessarily putting yourself or not yourself, the patient and someone else close to them at risk. Oh, actually, we forgot one thing. As common as child abuse is, one more thing which is common is actually elderly abuse. Elderly abuse is also very common, and the most presenting symptoms would be that similar to child abuse, that they might not have fractures or anything, but they might be missing their medications, their conditions or their diagnosis would be worsening, they would be malnourished, they would be unwell, like grooming wise, they would be not well groomed. Sometimes they might also present with bruises. And one ethics question that you might come across is that whenever you have child abuse or whenever you have elderly abuse, you do need to report them. Sorry. Yeah. Whenever you have child abuse or elderly abuse, you do want to report these people. But the difference is that whenever you have adult abuse, that means the spouse is being abused, or the spouse is being abused. So whenever that happens, you cannot call protective services on them because they're not considered a vulnerable group. And instead, what you might do is you can ask them if they feel safe to leave the hospital. If they do feel safe, then yeah, you can let them go. If they say that I do not feel safe, only then can you take some action. But you cannot call protective services for those patient population. So I think we can start these childhood disorders and early onset disorders from tomorrow. And then today we'll just go through a few questions.
Okay.